Thank you very much, Howard, and I'd like to thank the ICS Scientific Committee for inviting us to present our work here this afternoon. So I'm going to be covering patient-reported outcomes, looking at their role to evaluate Litoxetine as a potential novel treatment for mixed urinary incontinence. My name is Dudley Robinson. I'm a consultant urogynecologist from London, and I'm presenting this on behalf of my co-workers in Canada and throughout Europe. And these are my relevant disclosures. So Litoxetine is a selective serotonin reuptake inhibitor and multifunctional serotonin agonist-antagonist. We know that serotonin affects neural control within the bladder at both central and local levels, and it exerts these effects due to differing serotonin receptors. It has an inhibitory effect on detrusor muscle activity and an excitatory effect on the urethral sphincter. So far, Litoxetine has completed phase 2 clinical trials, and these have been previously presented at the EAU this year. And overall, they showed a treatment effect to reduce incontinence event frequency, and also showed that Litoxetine was safe and well tolerated. So this is the phase 2 trial, which was an international multi-center randomized double-blind placebo-controlled study in women complaining of mixed urinary incontinence. So you can see, following an initial screening period, patients then entered a single blind run-in period, which was blind to patient. They then entered the double-blind treatment period and were randomized 1:1 to 1:1 to Litoxetine 40 milligrams once daily, Litoxetine 20 milligrams once daily, 40 milligrams once daily, and placebo. Treatment period lasted 12 weeks, and then there was a tapering period at the end where patients reduced the dose just to once daily, and then follow-up was after 4 weeks. So first of all, if we look at the efficacy data, now this has already been presented, but I just thought I'd show a summary slide so you could see what the outcome was. And you can see a reduction with both the 40 milligram dose and the 20 milligram dose of Litoxetine, although not a significant reduction with the 10 milligram dose or placebo. So that was the efficacy data. Now, the focus of this presentation is to look at patient-reported outcomes, and we did this using the PGI-I, the PBC, and also the King's Health Questionnaire. So first of all, if we look at the results of the patient perception of bladder condition, you can see a significant and sustained reduction with Litoxetine 40 milligrams during the course of the study, and also a reduction with both 10 and 20 over placebo. If we move on to the King's Health Questionnaire, again we see a reduction with all doses of Litoxetine, but it was really the 40 milligram dose that was separated from the 10 and the 20 milligram dosage. And finally, if we look at the PGI-I, we see something slightly different, and here you can see a greater effect with the 10 milligram dose as compared to the 40 milligram dose. And this may reflect the fact that the PGI-I is a global impression, and therefore maybe you're seeing a cost benefit, if you like, of efficacy versus adverse effects as well. We then went on to do a responder analysis. So this was looking at the proportion of subjects having a 2 or more point improvement on the PBC and the PGI-I, or greater than 15% improvement in the KHQ, which is a minimally important difference. So first of all, if we start with the patient perception of bladder condition over on the left-hand side of the slide, you can see a very clear dose response with around 65% of patients achieving a meaningful difference with the 40 milligram dose. In the middle, we have the KHQ results, and again, around 70% of patients here achieved a meaningful difference in those patients taking the 40 milligram dose. Coming over to the right, you can see the differentiations less clear with the PGI-I, but still you can see a slight dose effect with the 40 milligram dose here, having a similar effect to the 10 milligram dose. What about the safety data? Well, overall, the drug was well tolerated. You can see nausea was the commonest side effect, which you would expect with an SSRI, in around 12.5% in the 40 milligram dose, dropping to 6.3% in the 10 milligram dose. But I think it was reassuring to see that treatment discontinuations due to side effects remained low, 12.5 in the 40 milligram dose, 7.7 in the 20 milligram dose. So in conclusion, I think this phase 2 study has demonstrated that Litoxetine shows a treatment effect which is clinically meaningful. We have efficacy data. We now have patient-reported outcome data. The effects seen at the 20 and 40 milligram twice-daily dose, I think we'd agree that the 10 milligram BD dose is ineffective. patients report an improvement in patient-reported outcomes using those 3 parameters, and also quality of life. The safety and tolerability data would appear to be good. Very few patients discontinued the study due to treatment emergent adverse events, and they tended to be mild or moderate and recovered spontaneously. So in conclusion, I would like to suggest that Litoxetine could be a valuable treatment option for patients suffering from incontinence, and this data from the phase 2 study supports the progression into phase 3 studies, which is now underway. And thank you very much for your attention.
Any questions? You know, again, we can see the placebo is fantastic.
It's a good drug, isn't it?
It's a really good drug. Do you think that if you use the tablet for a longer period, you would be even? Do you have any data or any notion of if continuing and the results will get better?
Not from Litoxetine, I think, because Litoxetine is a SSRI, although different to Duloxetine, which of course is an SSRI as well. And interestingly, in the Duloxetine studies, there was also a very high placebo effect as well, of around 40%.
Yes.
We don't have any long-term data on Litoxetine at the moment. Duloxetine, you tended to see a prolonged effect in the longer term. So I would hope we'd see something similar with Litoxetine.
We'll hope for that.
We'll get back to you on that one.
Okay. Any more questions?
Kato from Nagoya, Japan. Thank you very much for your beautiful data. And what kind of patients are the best indication for this drug? A pure SUI, MUI, or overactive bladder?
I think Litoxetine, we were very interested to look at a drug for mixed incontinence, and that's because of its effect on the detrusor muscle and also on the sphincter. So all of these patients had symptoms of mixed incontinence. We had no urodynamics data on these patients, so symptomatic mixed incontinence, and that's who the drug's targeted for.
And nausea, does it continue or transient?
Again, I can only talk about the 12-week trial with Litoxetine, but if we extrapolate from the Duloxetine data, the nausea rates with Litoxetine are much lower than Duloxetine, but with Duloxetine, nausea tended to get better over time and the patients became more tolerant of it. So I would hope that would be a similar thing with Litoxetine, but nausea is much less of a problem.
I see. Thank you.
Thank you.
Okay.
Thank you very much.
Thank you very much.